स्टूडेंट्स भी आएंगे?
नहीं, ऑनलाइन सर।
पहले मैं कमेटी में उसमें था कि स्टूडेंट्स के लिए आना है और जो कितने क्राउडिंग में थोड़े बहुत तो कोई भी नहीं आ रहा। हम लोग स्टूडेंट वाला ज़्यादा सबसे आते हैं, तो बहुत इतनी मेहनत की और कुछ कोई फायदा नहीं है। इतने इंपॉर्टेंट सेमिनार्स के लिए नहीं आते हैं। चलो करेंगे। So you are coming to Dr. Rutra, Dr. Manish है ना?
उनके नाम है, बाकी डॉक्टर मनीषा डॉक्टर रुद्रा है।
आप कब बोलना चाहते हैं?
आपके पास
रेडियोलॉजी वाले पता नहीं कब, नॉर्मली तो उससे इन्वेस्टिगेशन में वो बोल दे तो ज़्यादा अच्छा है। चलो कर ऐसे क्यों आ रहा है सारा? चलो ठीक है, शुरू करें। कैसे पता लगेगा बच्चे ऑनलाइन है? आपके पास होगा जूम एक्सेस? कितने बच्चे आ गए? 5। रिपीट क्यों रहेगा?
20 सेकंड बाद
20 सेकंड आता है। तो इनका सीआर कौन है जो क्लास प्रेजेंटेड है वो? ये किस प्लेटफॉर्म पे हो रहा है?
ये सर ओबीसी है, टेलीमेडिसिन और
नहीं, आई डोंट थिंक इंटरेक्शन हो सकती है ना इसमें। तो इन लोगों ने अजीब, जूम सबसे बढ़िया है, बट आई थिंक दे हैव केप्ट ऑल दिस।
तो नॉर्मली सर एक प्लेटफॉर्म पे जिप्सी पे करते हैं, AIIMS LT2 पे
जिप्सी वाला।
हां जिप्सी वाला तो उसमें
इंटरेक्शन होता है। किसी को यूट्यूब लगा?
हां
यूट्यूब पे नहीं होता।
यूट्यूब पे
यही मैंने अपने सेमिनार के लिए बोला था, हमारा एक बिजी हुआ है इंटरेक्शन में। तो शुरू करें। तो
सर इतने 4-5
भी नहीं है, तो पुराना चैट है ये, चैट से पुराना।
YouTube पे जाके there's no way to know how many people are
फ्री वॉचिंग ना हो।
फ्री में से
कोई प्लेटफॉर्म उस दिन मैंने राजीव को भी बोला, तब भी उन्होंने इतनी बड़ी बातें उन्होंने Zoom बेस्ड है, विदाउट इंटरेक्शन तो इज जस्ट might as well sit anywhere in the car and give it.
The best is तो वीडियो बना के देते हैं आपको।
बिल्कुल
वीडियो
सर वैसे करते हैं वीडियो।
आईडी ऑफ दीस थिंग्स बिकॉज़ इसमें तुम इंफॉर्मेशन तो लिमिटेड दे सकते हो ना, सो दैट इज। तो कैसे शुरू करना है? यहाँ इसके थ्रू शुरू करना है या
उधर
कहाँ पे बोलना है? यहाँ पर? अच्छा, बैठ के बोलना है।
हाँ जी
ओके। और ये क्या है?
ये माइक है सर।
ये माइक है। ओके, शुरू करते नहीं, पहले ये सब खत्म हो जाए करके। Good afternoon, everyone. Today we have an important seminar on peritonitis and subphrenic abscess. This is an important topic because it's a common surgical emergency in general surgical practice, and all of us, whether we are surgeons or not, should know how to manage it properly. At least the pre-surgical part of it should be very clear to everyone. So this seminar, we have 4 faculty members. Myself, I am Sandeep Agarwal. I am a professor of surgery in the Department of Surgical Disciplines. I have with me Dr. Vishesh Jain, who is a faculty associate professor in Department of Pediatric Surgery, where he is going to talk about the conditions in pediatric surgery which lead to peritonitis, which are a bit different from the adult causes. Professor Anup Saraya is the head of Department of Gastroenterology Department, who will be talking about various aspects related to the gastroenterology or the non-surgical issues. And Dr. Manisha, who is a consultant in radiology, who is going to talk about the radiological investigations as well as interventional issues when it comes to management of localized abscesses. So we're going to have a brief introduction of the topic, the causes of peritonitis, the presentation, diagnosis. We can then talk about causes in children, diagnostic imaging and management. This is the outline. We'll see how the other colleagues, when they come, will try to fit in and try to present you a comprehensive picture of the topic. So peritoneal cavity is is lined by 2 layers: peritoneum, which covers the anterior abdominal wall, diaphragm and pelvis. It's innervated by somatic and visceral efferent nerves, and that's why there are it has a pain perception. While on the other hand, visceral peritoneum, which lines the various visceral organs like the small bowel, is insensitive and receives efferent innervations from autonomic nervous system, and that's why the stimuli from these are very poorly localized. So what is peritonitis? It's an inflammation of the membrane that lines the abdominal cavity and the organs. So any itis means inflammation, and it's an inflammation of the peritoneal lining, and what it results is in a uniform inflammatory response to various stimuli. So whatever be the cause, the response is same, that there is an intense inflammation with a exudative, there's a cellular response and an exudative response, which in turn leads to a clinical condition called peritonitis, which has common clinical features, although the cause may be different, and hence this can be localized or diffuse. And when we talk about peritonitis, unless we mention it to be localized, we mean a diffuse peritonitis. Okay, so if it is localized, we will say it's localized, but when it's only peritonitis, it means a generalized peritonitis. So the physiological response depends on that means the inflammatory response depends on the virulence of the contaminant, how virulent it is, the size of the inoculum. For example, if there's a perforation in the bowel, is it a big perforation? Is it a small perforation? The virulence of the contaminant if the bowel was obstructed, the load of the bacteria is much more, and if there is a perforation secondary to obstruction, it will lead to higher virulence and higher load of the inoculum. The immune status of the host is obviously important, as you know, in current COVID conditions. Everything depends on the immune status. If you have good immunity, you can fight and you have a good inflammatory response, and you really do not go down so fast. But if it happens in an immunocompromised person, like somebody who's on steroids or somebody who has a terminal malignancy, or other conditions will lead to decreased immunity, they tend to go down very fast. And then the local environment of the peritoneum. So there's a bacteremia because of the initial insult, and there's a cytokine release. What it leads to is significant fluid shifts. This is important to understand because there's a huge extracellular sequestration of fluids in peritonitis, and that's why the adequate resuscitation involves huge amount of fluids to be given, and I'll talk about it later when we discuss the management. This edema formation, all the tissues in the peritoneum, for the bowel wall or any other, all the structures, they show intense inflammation and edema. This sequestration of fluids in the third spaces like bowel wall, retroperitoneum and abdominal wall. And there are coagulation deficits which can lead to bleeding and oozing. I'll just show you a small video to appreciate how bad peritonitis is. It's just not a clinical term. It means pus inside, and pus, not only a few ml of pus, it's liters of pus. So this is what you see in a advanced peritonitis. You can appreciate all this feculent discharge of feculent purulent matter all around. That's the liver, leftover liver. That's a subphrenic area. And this is just a laparoscopic video as an illustrative thing. Where have we lost? So yeah, again. So this is a laparoscopic view, just to make appreciate the severity of this condition. It is not just a simple clinical term like localized abscess or anything. This is a really bad. Can you see the edema of the abdominal wall, the inflammation of the parietes, the fibrinous strands, and some adhesions. So all this muck. So this means there's a lot of inflammatory material which needs to be which is throughout the cavity, and it can be liters of pus inside, and that's why the condition leads to such an intense reaction, SIR and hypotension and large fluid requirements. So this has occurred secondary to some perforation, and I am not going to probably show you the whole video because that was not the intention of this video, just to make you appreciate that this is not an innocuous condition. So when you come to classification of peritonitis, roughly is divided into three types. Primary or spontaneous peritonitis, which occurs in certain conditions, like patient having ascites secondary to cirrhosis or due to chronic renal failure, but there is no actual perforation or any perforated viscous, or this just occurs as a part of a bacteremia, which could be spontaneous, like hematogenous spread of bacteria, or sometimes can be ascending through in the females. Ascending primary peritonitis. What we commonly, when we talk about peritonitis, is the secondary peritonitis, especially in surgery. When you say peritonitis, it would mean secondary peritonitis. And the commonest cause, remember, is perforated viscous. There are other causes I'll discuss, but remember, as a one cause, perforated small bowel is the commonest cause of secondary peritonitis. And then comes the tertiary peritonitis, which means a peritonitis or a residual infection which occurs after adequate initial therapy. That means once you have treated secondary peritonitis, you have operated, you have taken care, after some time patient develops a localized abscess or again some leak, and which leads to persistent or a recurrent infection, and that's normally labeled as a tertiary peritonitis. It can also be classified as I said earlier, was as a generalized peritonitis. That means all the compartments of the abdomen are affected, which is a more common condition, and a localized abscess which can occur in various locations, the commoner being the subphrenic regions, the pelvic abscess, the appendicular abscess. These are localized abscesses that will pass surrounding that region, and then there are other varieties of these localized infections. So as I said, perforated viscous is synonymous with peritonitis. It is the condition which causes peritonitis. It leads to a direct spillage of luminal contents into the peritoneum, and all the small bowel contents and the colonic, they have a high bacterial count, especially the colonic contents, and that leads to a gram-negative and anaerobic bacteria being spilled into the peritoneal cavity. And among these are the E. coli and Klebsiella pneumonia are among the common bacteria, and then they lead to severe inflammatory response, endotoxemia, and as said, and I won't go into details of this because I'm sure these have been discussed separately in some physiology or other lectures, pathology lectures. So what it leads to, a cascade of events which leads to damage, septic shock, and multi-organ failure. So what are the common things? Now you should remember 3 or 4 common causes of common perforations which happen, which we deal in surgery. So appendicular perforation is probably one of the commonest perforations we see. Other perforations which are common are duodenal ulcer perforation or gastric perforation. Normally duodenal and gastric, initially before the surgery, they are clubbed as a peptic ulcer perforation, because that time we may not be clear which ulcer has perforated, whether duodenal ulcer or gastric ulcer. So we normally can club them as peptic ulcer perforation. And the third commonest cause is enteric perforation due to typhoid fever, which presents in the either beginning of or end of second week in a patient who is presenting with high grade fever as a perforation peritonitis, and I'll talk briefly about it later
And of course, we have the colonic perforation as a result of obstructing malignancy or a diverticulitis. And sometimes it can be iatrogenic, supposing a patient is undergoing colonoscopy examination and there is an injury to the bowel wall. That is also not an uncommon cause of colonic perforation. So remember, perforation, peritonitis, these are the common causes. Very easy to remember: appendicular perforation, peptic ulcer perforation, enteric perforation, and then colonic perforation. Although small bowel perforation can have other causes, but remember, typhoid perforations are the commonest in a setting. So these are the examples of some of these. Okay, so this is a gangrenous bowel which is perforated here, and and there is a perforation here. So these are the common causes of perforation. That's again a perforation in the small bowel. Okay, which can it can be small, it can be big, it can be proximal to a stricture. So all these things can happen. So as I said, these are the common causes. I won't repeat that. Then other causes which are not perforated, supposing there is no perforation, can be a strangulating obstruction, which can lead to a gangrene. As I said, this can you appreciate this black bowel? There's a gangrenous bowel which can occur as a result of a prolonged unresolved obstruction, or it could be due to another non-viscous ruptures like liver abscess which has ruptured. These are uncommon causes. Remember, these are common. Depending on the history of the patient, we can diagnose this. Pyosalpinx which has ruptured. Biliary peritonitis again is an uncommon as a cause of secondary peritonitis. It normally happens as a result of bile leak following surgery, sometimes gallbladder surgery or a biliary surgery. And again, as an NTD perforation of gallbladder is extremely uncommon. In my own whole career, I must have just seen 1 or 2 cases. Out of so many emergencies I've seen. So remember, so hollow viscous perforation is the commonest cause, strangulating obstruction, then the other abscesses which have ruptured into the peritoneal cavity, and the biliary peritonitis normally is secondary to some procedure. Okay. So now coming to the symptoms. What is the issue with peritonitis? It causes intense pain. Remember, peritonitis without pain is unheard of, unless patient has some other neurological issues. So pain abdomen is the main symptom. It is severe pain. Patient is really restless, tossing around in the bed initially, and it can be very abrupt onset. Patient normally says it's really started very suddenly, because the perforations, when they occur, they present very suddenly. Okay, so this is an abrupt onset of pain abdomen. The pain may be localized initially. Supposing there is a peptic ulcer perforation, the duodenum is located in the upper part of abdomen. So when it perforates, the perforation occurs typically in the anterior wall of the first part of duodenum. Okay, that's the typical location of a peptic ulcer which perforates. So that causes an intense pain in the epigastrium initially, and after that, when the fluid trickles to the right side, the patient develops the right-sided pain and then becomes generalized. So you sometimes, based on the history, you can diagnose the cause of perforation. For example, epigastric pain at the onset followed by generalized pain will lead to a diagnosis, most likely a diagnosis of peptic ulcer perforation. If the pain started, patient has had appendicitis symptoms, and then patient has an abrupt onset pain in the right iliac fossa, it could be appendicular perforation. A patient who is giving a history of high-grade fever for a week, let's say, high-grade fever with toxemia, and then has pain abdomen, which getting severe, could be enteric perforation. These are general clues. They are not like hard and fast rules, but they give you a very good clue to the possible cause of diagnosis of peritonitis. Nausea is rare, but vomitings can happen because of the reflex there's a reflex pylorospasm. Whenever you have abdominal pain, you can have a reflex pylorospasm which can cause non-bilious vomitings, or if patient has peritonitis with ileus, that can lead to bilious vomitings. So vomitings again are common with peritonitis. Because of the severe pain, patient has deep breathing, the difficulty in deep breathing and coughing. They have shallow breathing and shallow rapid breathing, and all these maneuvers, deep breathing, coughing, any movement. Patient says you ask them to turn, they will have pain because any movement or all this. So these are all indicators toward peritoneal signs. These are called peritoneal signs. And then again there can be some non-abrupt issue when the patient has obstruction initially followed by perforation. They can have colicky pain initially, and then leading to a perforation, which can have which will become a continuous pain then. So all these things, you know, have to keep in mind, and that's why in an acute abdomen, history taking is an extremely important point, which gives you a real good clue towards the cause of peritonitis. So let's talk about one of the commonest causes of peritonitis, that's the perforated peptic ulcer. And initially the duodenal ulcers are more commonly seen to be perforated and more than gastric, although that ratio is a little bit changed. Still duodenal are more, but gastric ulcers perforations are becoming commoner also because of increased incidence of gastric malignancies. Typically male patients between third and fourth decades are the usual patients. They may or may not give a history of previous peptic ulcer symptoms, like they may not have a history of acidity or nocturnal pain, which you have read in peptic ulcer symptoms. Sometimes a perforated peptic ulcer may be the first symptom of peptic ulcer. So it could present just as perforation for the first time. And sometimes a patient may give a history of an NSAID intake for some other condition like joint pains or some other thing. So that may lead to an acute peptic ulcer formation and perforation. What is the characteristic of this pain is a sudden onset pain in epigastrium. So the patient can tell you, exactly what was the patient doing when the pain started. It is like a balloon rupturing in your abdomen. You can tell, look, it was 1 o'clock at that time when it perforated, or when the pain started, or I was actually working on the computer when it started, or almost exact moment the patient is able to point out in some cases, and that's almost, in my own experience, a very, very good clue to a duodenal ulcer perforation. A very abrupt onset of pain in the epigastrium, obviously which will become severe later, is a good clue to a perforated peptic ulcer. So signs, what are the signs? Now examination is again a very important point for diagnosing peritonitis. Even at this era of CT scans and MRIs and very advanced laboratory investigations, we as surgeons we really depend on signs for diagnosis of peritonitis. And obviously the signs depend on etiology and duration. Supposing patient presented within 2 hours of pain, they may not have generalized signs. They may have just a tendency in one particular compartment, but that's obviously an unusual thing. Most of the patients present with frank peritonitis, that means they have diffuse tenderness. So when you examine their abdomen, they may be totally rigid abdomen. Abdomen may not be moving with the respiration because any movement causes pain. There may be a generalized fullness of the abdomen, and when you try to palpate the abdomen, there is a marked guarding and rigidity. Guarding means you feel that the abdomen is not soft. There is some sense of a resistance to your palpation, and so all these are signs of peritonitis. Of course, the generalized signs like tachycardia are extremely important. It's very unusual for a patient with peritonitis to have a normal pulse rate. Okay, unless they are on beta blockers or some other thing, but tachycardia is again very important clue that something is wrong inside. Any pulse rate of 100, more than 100, even if the abdominal signs are very equivocal, should be taken with suspicion in the setting of other symptoms. Again, fever will depend on the duration. If it's a late presentation, patient may have a high grade swinging fever. They are obviously ill and restless. This is not an innocuous condition. As I said, it is a very, very serious condition. And they may have normal blood pressure, or they may have a slight lower pressure depending on the time of presentation. Okay, and we'll discuss these things later. So these are the signs I was trying to discuss. So patient is ill, is anxious and dehydrated, there is tachycardia, there may be hypotension, they have a shallow rapid breathing, they are trying to lie still, not move too much, and abdomen is normally distended. You may have absent bowel sounds because of severe inflammation. This diffuse tenderness to percussion, board-like rigidity, and rebound tenderness. Rebound tenderness is when you try to palpate, there is tenderness. When you leave the abdomen, suddenly there is intense rebound pain, and again is a very, very fairly diagnostic sign depending on how experienced you are in eliciting this sign. Okay. Again, another sign which some people totally forget to examine is the obliteration of liver dullness and percussion. So, as I said, the commonest cause of peritonitis is your perforated viscus. So, when you examine these patients, so there should be air. When there is a hollow viscus perforated, there is air in the abdomen which rises above the liver and the normal liver dullness which starts in the fifth intercostal space is obliterated and you feel a sort of a resonant note on percussion. Again, may not be present in all cases, but if present is diagnostic of a pneumoperitoneum. Okay. So again, absence of this sign does not exclude peritonitis. Actually, absence of no sign excludes peritonitis. It's a combination of your symptoms and signs. Now, when the abdominal findings are unreliable, when patient is old, they have a lax abdominal wall which may not show rigidity. Anyway, they are immunosuppressed. They don't show all the signs of inflammation. They may not throw fever. They may not be able to tell you exactly where is the pain. They are in altered sensorium, or if they are paraplegic. You want to talk before me, or you should cover? So again, coming to the diagnosis of peritonitis, as I said, it's clinical. Okay, all the other investigations are secondary. The diagnosis is clinical in all respects. For even in the present era, a good detailed history and exam, there's no replacement for that. Okay, it requires patience. You may need to take history from the relatives and attendants. You may need to examine another time, maybe another half an hour or 1 hour later. You may need your colleague to examine. Even at this stage, after 20 years of working in surgery, sometimes I ask my colleague to have a look, even my junior to have a look. What does he think about that sign? Okay, so it's a combination again, because the clinical thing is so important, and you may need to take a opinion from your peer, and there should be no hesitation in doing that. So once you've done, you're fairly clear in most of the cases that is peritonitis or not. If it is not, you can examine a few hours later, or obviously there are some investigations which can be done. And among the most useful investigations is a plain chest radiograph in the erect manner. That means either the patient is standing or sitting. But because this patient is so sick, you may need, they can't sit or stand, you may need to make the patient lie down in one of the positions, one lateral position, the left lateral. That means the patient is on the right side down. And sometimes you can see the air against the abdominal wall. Now remember, when you have to wait after changing the position for a while. If you immediately change the position and take the X-ray, you may not get the air on the X-ray. So it's better that while the patient is waiting for the X-ray, they can lie down in one of the lateral positions before the X-ray. And of course, ultrasound and CT abdomen, I think Dr. Manisha will going to talk about as a part of the investigations. So this is what I was saying about the plain radiograph, one of the most useful simple investigations available anywhere, even in district hospitals or even in primary health centers, where this side, can you see the diaphragm here? This is the diaphragm. So this is an X-ray chest, remember, this is not an abdominal X-ray. So see the lungs, you see the diaphragm markings, and then you see this free air. These are large amounts of air. Sometimes you can just see a small sliver of air here, not this large amount of air. And this is again diagnostic of free air, and then obviously there is possibly no other cause except a hollow viscous perforation. But remember that even in cases of hollow viscous perforation, free air is present in only 3/4 of the cases. And again, absence of air on the X-ray does not preclude the diagnosis of peritonitis. So when do you see free air? It's common with peptic ulcer perforation, common with colonic perforations, but then unusual to see in air in appendicular perforations, because the amount of air is so small, and presence of free air, as I said, is not mandatory for diagnosis. And it can, sometimes you may not be able to, in a busy emergency, may not be able to see that small amount of air, which can happen with all of us. We sometimes miss that small sliver of air beneath the diaphragm. And so again, a combination of everything is important for making a diagnosis. Now, once we made a diagnosis, now this is probably the most important slide for you guys. Whether you plan to become surgeons or not, this is what you must remember absolutely, point wise, that this has to be done when the patient is being prepared for further management. Okay, so supposing you are a CMO or a medical officer in the casualty. So first, once you recognize, obviously you will call a surgeon, immediately put a nasogastric tube to decompress the stomach, because these patients have gastric ileus. One, they swallow a lot of air during the pain. When they have pain, they are having a shallow rapid breathing, so they swallow a lot of air into the stomach, and also there is the ileus of the bowel. So all these needs to be decompressed using a nasogastric tube. which is available everywhere. You must, think of these steps. So restoration of intravascular volume deficit, put into IV lines, take the blood for samples, hemogram, count, CRP, and other parameters, electrolytes especially. And what does it involve is, if the patient is mildly hypotensive, immediately give 2 liters of fluid over next 20 minutes, 15 minutes, as fast as possible, because fluids is the only thing that will bring up their pressure. I have seen so many times, even now, when the patient has not been given the fluid in the casualty, they have been started on noradrenaline, adrenaline and vasopressin, without realizing there is a obvious shortage of fluid there. And in general, these patients have a deficit of 10 to 15 liters of fluid when they present. And why is that? Because they have been vomiting, there are serious third space losses, and they have not been taking anything orally. All these things combined together lead to a very serious fluid deficit. If you remember that, I think that I'll be successful in taking this lecture. Remember, fluid deficit is huge, and you can never go wrong even if you give too much of fluids, except if patient has congestive heart failure or a severely cardiacally compromised patients. In general, these patients require fluids, and not inotropes initially. So once you start giving fluids, obviously you can put a central venous pressure line and a catheter to monitor their urine output. And urine output is one of the good indicators of a fluid resuscitation. Obviously, we can depend on other parameters like central venous pressure line or a catheter, depending on the patient's condition. Catheterize the bladder. Okay, these again, you don't require a surgeon or a specialist to do it. Get it catheterized. Start broad spectrum IV antibiotics immediately. Once you diagnose peritonitis, it's a serious infection, remember. You cannot omit starting antibiotics saying no, surgeon will come and decide. Start broad spectrum IV antibiotics. These need to be taking care of the community acquired infections, okay? Because these patients are coming from the community, they don't have mostly antibiotic resistant bacteria. So you need to just give a second or a third generation cephalosporin or even a first generation cephalosporin along with metronidazole, okay? And there are various combinations, but remember, you start the most, you don't have to have the highest grade antibiotic even if the patient is in shock. That doesn't help. The shock is due to fluid deficit and other problems. What they require is antibiotics which are based on obviously hospital policy, but again, don't be starting like piperacillin, tazobactam or magnemycin or something. They don't require that. Just a combination of antibiotics covering all the bacteria is good enough. And again, remember, if the patient is hypotensive, oligouric, having a shortness of breath, they may need to be intubated electively because they may suddenly collapse and die. So remember, if they have septic shock and altered status, intubate electively rather than in an emergency when they arrest. So I hope you remember all these 7-8 points, because even if you are not a surgeon, you need to do these things while waiting for surgeon to come or while waiting for surgery. And don't forget pain relief. These patients have severe pain, and all they want is pain relief. So intravenous, not intramuscular, not oral, not through any other mode except intravenous narcotic analgesics are the drug of choice. You can give IV paracetamol, again 1 gram is good, but I think they normally require IV morphine or IV or IV fentanyl for pain relief. So just to again stress, aggressive fluid resuscitation, initial 2 liters over next 20 minutes and then again few liters over next few hours. Avoid pressure agents unless your CVP is now normal but still pressure is low, then you can start inotropes. That's the time when you have to start inotropes. And frequent monitoring of various parameters like blood pressure, pulse rate, and obviously these patients have to be operated within next few hours, okay? But then again, this preparation for surgery is important because if you operate immediately, they will collapse and have a arrest on the table. All this I have already talked about. Initial resuscitation and they may require other support. But again, I think the mainstay of therapy is surgery. And what you need to talk to this patient's relatives is a very serious condition which is potentially life-threatening. You need a consent for a laparotomy, oblique laparoscopy, whatever you are doing. You need always a consent for bowel diversion. Diversion means you may need to do an ostomy because these patients may have gangrene inside. You don't know what's happening inside. Enteric perforation, again, there can be multiple perforations, or the bowel may be very unhealthy to be closed. So a consent for ostomy beforehand goes a long way. Otherwise, when the patient wakes up and finds something coming out of his tummy with fecal matter, they don't accept it very easily. Arrange for ICU support. Okay, take this condition seriously. Discuss the seriousness of the patient disease with the family and the patient. So, what are the surgical principles of management? Okay, as I said, surgery is the treatment of choice, or is the definitive treatment. And these are the aims of surgery: is the early and definitive source control, reduce the bacterial inoculum, and prevent recurrent or persistent sepsis. So what is the main thing? Is to do a laparotomy, is to do a large midline incision. Again, when you are experienced, you can roughly make out what was the initial cause. So it could be an upper midline incision, or a mid-midline incision, or a lower midline, depending on the cause. Supposing it's peptic ulcer perforation, may give upper midline. The advantage of midline incision is you can extend in both directions, okay? And it's rapid, it's non-muscle cutting, and hence a midline incision is preferred in an emergency. It gives you a rapid access to peritoneal cavity. Next, what you look at is the cause of perforation. You systematically examine the abdomen. Meanwhile, before you look at the source, actually you aspirate, as I showed in my video earlier, you aspirate, suction everything thoroughly, so that all the inoculum is taken away as soon as possible. All the pus, the purulent material, all the muck is taken away by using good suction cannulas. And then you look at where it is being, where is the perforation, what is causing all this, and then you tackle that. And once you have tackled that, you do a lavage. Now, lavage is an important part of a peritonitis management. That means you wash the cavity. It's like a tank. Okay, it's a dirty tank where you have to put liters of water. So whenever we start the surgery, we ask our nursing assistants to keep 10 to 20 liters of fluid in a warmer, so that we can wash it thoroughly, because there's no shortcut. You have to wash it thoroughly so that the returns are clear. And put drains, which is a bit controversial. And in some cases of early peritonitis, there's a definite role of laparoscopy, which is coming more and more into the management of peritonitis. So as I said, vertical midline incision, I won't go into details. Just remember that tissues are very friable and we have to be really gentle in handling it. So let's go by cause. Duodenal ulcer perforation, what is known as, so how we close it, what is known as omental patch closure. It goes by various names, gram steel closure and other names. So what is done is, pedicled patch of omentum is put. I have videos on this. I had a video. So I just show you a small video. Okay, so this shows a perforation. That's a perforation in the first part of duodenum. That's the liver, gallbladder. That's the first part of duodenum. That's the callus triangle area, the porta, sorry, not the callus. And we are taking sutures. Okay, so we take few sutures. I'm just showing a laparoscopy so that you can see it. Open thing is very difficult to show, but the general practice is do a open laparotomy in most cases. Okay, remember that. So don't say in exam that we'll do a laparoscopic repair. This is just to show you how an omental patch closure is done. So we take 3 sutures. We don't tie them. We just take it one through the center, one above the perforation, and generally these are very small perforations. There is generally pinpoint perforations, but sometimes they can be large, like in this case. So we take these sutures and then we put so again you can see the tissues are very thick, and because of the inflammation. And then once we've taken them, okay, now we get omentum, which is vascularized omentum. We don't divide a piece of omentum. We get it, so that is from the transverse column. We lift this free omentum patch. We place it across the perforation. So it is covering the perforation, and then just we tie the sutures loosely around it. So remember, we are not closing the perforation primarily, because that will lead to a narrowing of the duodenum. Okay, so this method is very, very effective if you done properly, and it's a fairly simple. There's no rocket science in it. Anybody with a reasonable surgical training can do it, and in fact is one of the commonest surgeries which residents are trained to do in emergency. Okay, so you tie the sutures gently but snugly without strangulating the omentum, and that's it. And you give a thorough wash, as I said. After you've closed it, do a thorough wash of the peritoneal cavity. So this is what is known as a omental patch closure. For a gastric ulcer, we always take a biopsy. For duodenal ulcer, biopsies are never taken. They are normally peptic. But gastric ulcer can be secondary to a malignancy. And they are always closed in 2 layers, or sometimes you may require a resection of the part of the stomach. Appendicular perforation again requires an appendectomy in most cases. Again, the principles remain same: removal of all pus, septic material, and a thorough lavage. I will skip this video. I think it get lost long. If you see, just quickly, can I run? I think it's I'll get too much. Enteric perforation, again I said there is an initial history of high grade fever with pains occurring 7 to 10 days later. And these patients are extremely sick because they already have a underlying disease like enteric fever, which is a serious condition. So they're sick, they're moribund. And again, now there are enteric perforations, they may be managed by different ways depending on the severity of peritonitis or stability of the patient. Patient may be hemodynamically stable. So you may close the perforation by sutures. You may take out that segment of the perforated ileum as a ostomy, or you may resect it, the segment containing the perforation, with joining them anastomosis or ileostomy. So these are the options: closure of perforation, resection anastomosis, resection diversion, and exteriorization of perforation as an ostomy. This is what I mean by an ostomy. Okay, so this is what is the bowel is brought out into the outside the anterior abdominal wall, so that all the contents drain outside. Sometimes one might require damage control surgery. That means you are not able to do any repair, but you can drain the pus and the abscess and take out the intestine proximal to it, so that all the enteric contents are diverted. You have not been able to close the perforation. This is a very rare situation, and but normally we are able to close the perforation and control the source of pus. Now the next step is the closure of the abdomen. These patients have very edematous bowel, which is in ileus. They have a lot of inflammation in the abdomen, and once you open it, it's very sometimes difficult to close these abdomens. In some cases we are able to close it primarily, but sometimes, especially in enteric perforations, where the patients are very sick and there are chances of reperforation there, we prefer what is known as open abdomen technique, where we leave the abdomen open and we use various materials to close it with these materials. This can be a vicryl mesh, this could be a vacuum assisted device, a velcro like closure device, or a PTFE mesh with zipper. So this is what is known as a laparostomy, or an open abdominal technique. Useful in extensive peritonitis, because sometimes if you close it, you can have an abdominal compartment syndrome, which can lead to serious consequences. And even if you try to close it, it will burst open in the next 24 hours or 48 hours, and will cause more problems. So it's better to leave it open then. So these are the things I was saying. These are the temporary ways to close the abdomen. This is a zipper, okay, commercially available. You suture the edges to the cavity and put a zipper, or you can use a Whitman patch, or what sometimes we can use is a vacuum assisted device where we can put a foam. But what we commonly use in our own institute is a Euro bag. Okay, it's very inexpensive. So a sterile Euro bag is open. Euro bag is what used to collect urine. It's opened. It's laid open into a sheet and is sutured to the edges of the interior sheath. And then so a zipper is made out of that bag. And every day we open the zipper, open the two ends of the Euro bag, wash the cavity, and close it. And it's been found to be extremely effective. Obviously, it is inexpensive and also prevents all the problems of a closed abdomen. And you can wash the abdomen every day. And obviously, these are the commercially available devices which can be used. Okay. So open abdomen technique is frequently employed in management of peritonitis to prevent abdominal compartment syndrome, reburst, and other problems. Post-operative care is very intensive. They may need to be shifted into ICUs. So you monitor the pulse rate, heart rate. Again, as I said, they keep requiring a lot of fluids. Don't forget that. Don't forget fluids in resuscitation. That continues intra-op and post-op period. Obviously, it has to be monitored by an early urine output and a CVP. Antibiotics are normally required for 5 to 7 days, not beyond that. We may need to change it according to culture report, and we continue their NG decompression. And normally these patients, who have done a good surgery, a good lava, they improve progressively over next 24 to 72 hours, like their pulse rate settles down, the fever spikes go down, they start feeling hungry, they pass wind in next 24 to 48 hours. So all these signs show improvement of thing. I think I'll stop there, and then you have come in, and then I'll cover the rest of it. Okay, is it okay, Ashish? Okay, so I'll stop here, and then I'll discuss the next part of it, that is the tertiary peritonitis or the subphrenic abscesses and other things. And meanwhile, Dr. Vishesh will talk about causes of peritonitis in children and how to manage it. Just minimize it. So maybe when you discuss and then you want to come in after that, or maybe discuss उसके बाद बताएं आपको कैसे
So good afternoon all. I'll be talking about basically the causes which are there in children, the causes of peritonitis. Many things are similar, and Professor Sandeep Agarwal has discussed very nicely the pathophysiology of this disease. So I'll be restricting myself to the changes that we see in children. So as you can see, this red markings are of the causes which are very specific and very common in children as compared to adults. Appendicitis, Meckel's diverticulitis we can see in adults also, but conditions like intussusception, midgut volvulus, strangulated inguinal hernia, necrotizing enterocolitis or enterocolitis and Hirschsprung disease, and meconium peritonitis. These conditions are very specific to kids, and we'll be talking about these conditions more in my subsequent slides. Another rare cause can be perforation of the proximal bowel if it's neglected. If there is a distal obstruction and the patient is not treated in time, and in children basically the bowel is very friable and not very strong. So in such cases there can be perforation of the proximal bowel, although this is rare, especially in cases of endothelial malformation, Hirschsprung disease, and rarely intestinal atrasias. Because of distal obstruction, if the proximal bowel is not decompressed properly and the patient is not operated early, then this can also cause perforation and peritonitis. Other rare causes can be, as mentioned by the previous speaker, can be cholecystitis, that is perforation from the gallbladder, which is rare. However, perforation from a choledochal cyst, which is a congenital abnormality in which there is abnormal dilatation of the CBD, is much more common, because these can be huge structures and usually they leak at the insertion of the cystic duct. Another thing which can cause biliary peritonitis is trauma. As we know, liver is a very common organ for injury, and these patients can develop biliary peritonitis. The rare causes can be gastric ulcer, it is very uncommon in children, and pancreatitis. So diagnosis history, as already mentioned, is very important. In our case, we have to take history from both kids if they are good enough, they are old enough, and also history from the parents. Also, a very important part of the history is to avoid taking leading questions. You should just listen them out and then later on take your negative history, and also speak to the child in a manner he feels that he is being involved in the disease process and the management. Age is very important in history, because if you see all these diagnoses, every diagnosis is very specific to this age. For example, if you see the patient of necrotizing enterocolitis, so you'll expect a term or a preterm child who is around 7 to 10 days of age, who maybe have some perineal event which made him more prone to this event, and that is the age group that you are looking for in patients of NEC. Similarly, if you're looking for patients with intussusception, you will basically looking for a child who is around 9 months to 3 years of age or 2 years of age, fairly well preserved, who presents with sudden pain abdomen. If you're looking for malnutrition, probably look for the child in early 6 months of early infancy who has recurrent vomiting and then presents with pain abdomen. So all these age and these presentations are very specific, through which we can get specific answers. Similarly, for Hirschsprung disease, there will be a child who has not passed stools in the first 24 hours of life and has constipation after that, and this child presents with recurrent diarrhea alternating with constipation. diarrhea signifies that basically the proximal to the obstruction, because of accumulation of feces and bacteria, there is bacterial overgrowth, which causes enterocolitis, which may present as passage of very false smelling stools and later on even as perforation. So age is important. Again, primary peritonitis has to be ruled out. So as we know, primary peritonitis is a peritonitis without any obvious intra-abdominal cause. So there are some susceptible group of patients in which we know that they are more likely to have primary peritonitis, and these patients can be patients with nephrotic syndrome, patients who have a peritoneal dialysis going on, patients who have hepatic disease and have ascites because of that, patients with ventriculoperitoneal shunt, patients who have splenectomy. So you know these patients are more prone to primary peritonitis. Again, the site of origin of pain can give you a good idea about the location. As we know, visceral pain is basically not very well defined, but we can have an idea because we know the foregut is supplied by the celiac axis, so the pain is maybe defined in the epigastric region, as pointed out that if there is a duodenal gastroduodenal perforation, then basically the pain is initially referred to in the epigastrium. Similarly, most of the perforations are there in the midgut structures, and that's the reason why we have the patient present with pain in the umbilical area, like appendicitis or Meckel's diverticulitis, or any perforation or ischemia of the small bowel will present with a periumbilical pain. And similarly, if the pain is in the hindgut, then the pain is suprapubic. But as soon as the parietal peritoneum is involved, which is very richly supplied by the nerves, then you can have a specific area which we can tell that what is the likely origin. As the best example for this is appendicitis, and which the pain is in the right iliac fossa, and you can make the diagnosis with very certainty on examination and the history itself. So examination is very important, especially in the child, because adult can be cooperative but the child usually are not cooperative. So you have to be very gentle with them, try to console them and get their favor, and then examine the child. It is very important to, again, if especially winters are coming, you should warm your hands properly, because if the child gets irritable once, if you put the cold hand, he won't let you examine. So it's important to develop a rapport with the child if possible and make him as comfortable as possible. Do not separate the parents and the kid, make the parents be near the kid so that you can examine the child properly. The vitals are important. As mentioned, there are huge shifts of the of fluid because there are huge third space losses, so we have to see for the features of hypovolemia. Very important thing in children is hypothermia. As you know, neonates and infants are very prone to hypothermia, so you have to make a suitable environment for them, and if they have hypothermia, you have to increase the temperature, use warmers, incubators, so that they can again become euthermic. Abdomen, as mentioned, basically the child is lying still. He doesn't like to move his abdomen because that will cause pain. So we can see the abdomen is red. There are shallow breaths, so that to avoid much more movements of the diaphragm, the child takes shallow breaths. The abdomen is warm. There is tenderness. So tenderness, we all know it's basically objective assessment during the palpation of the pain. So whenever you see tenderness, you have to define which quadrant of the abdomen the tenderness is present, whether it, and what pressure can we elicit it, whether it's superficial or it is deep, and what is the severity. If the child just wincing or he just removes your hand, that would give you idea that it's severe or mild tenderness. Guarding is a voluntary reflex by the child to prevent you from harming him. Basically, it's another thing that tells you that there's some kind of pain and he doesn't want to examine, and he is guarding his abdomen by contracting the abdomen. So guarding can be sometimes removed by deviating the attention of the child to some other matter by speaking to him, and guarding is usually generalized, whereas rigidity is an involuntary contraction and it's usually localized to that area. Rebound tenderness is also a good sign to diagnose peritonitis, and mostly in these patients, because of ileus, because of this infection, the ascites and the bowel sounds are less. Ascites can also be present in these patients, especially in patients who have spontaneous bacterial peritonitis, that is primary peritonitis. And ascites makes the diagnosis a bit difficult because it creates space between the organ which is infected and the parietal peritoneum, and because of these signs may be masked. So ascites sometimes causes difficulty in making such diagnosis. So as mentioned, laboratory investigations are important, and as mentioned earlier, a very good X-ray, especially with both the diaphragms included, is a very good initial investigation to diagnose any perforation, because that is the most common cause of peritonitis. The later on investigations like ultrasound abdomen and CCT abdomen will be discussed by Dr. Manisha in her subsequent talk. So treatment, as already been mentioned, we have to put these 3 tubes. That first is ABC. You have to see that the child is not gasping, etc., and you need to intubate the child immediately. So you have to see the airway breathing circulation. That is true for every patient that you see in casualty. Apart from that, putting of an nasogastric tube, IV access, urinary catheter, antibiotics, and IV fluids are very important. Analgesics are very important, but it should be given after first assessment by a surgeon or by the clinician, so that we have an idea about the tenderness and the severity of pain. Because once these are masked, the clinical signs also become a bit difficult. So analgesics have to be given, but it's better to examine the patient once. So also for antibiotics, especially in a scenario in which you are suspecting a primary peritonitis, it is imperative in those conditions you first do a paracentesis before giving antibiotic, because otherwise again the findings of the paracentesis may be a bit masked. So treatment is antibiotics, and in secondary peritonitis it's always surgery. Surgery is basically exploring the abdomen, finding the disease, controlling the source of the disease, of the infection, doing a good lavage and drainage, followed by post-operative care. So I'll be briefly talking about the very common causes like necrotizing enterocolitis, which we see in neonates. So it is a disease in which you have a susceptible host, that is a term or preterm baby who had some parental event like some ischemia, something in the parental event which has made him more prone to disease. You have virulent organism which is there in the ICU or in the surroundings, which is ready to invade his gut, and you also have some environmental factors like somebody is giving rapid feeds in this condition, or hypertonic feeds, or he's on some drugs like endomethacin, etc., which affect the gut barrier. So all these three things combined allow the bacteria to cross the gut barrier and go into the wall and cause intense inflammation. So as I mentioned earlier, the presentation is usually in the first week of life, up to 5 to 7 days, and you need a susceptible host and a virulent organism. Depending upon the findings, we can say it's a suspected NAC, it is a definitive NAC, or there is a complicated NAC. We know the Bell staging classification of this NAC. In suspected NAC, basically the child has poor feed intolerance, there is some abdominal distension, the X-ray may show dilated bowel loops, there is occult blood present, but the diagnosis of NAC is not very evident. But in a definite NEC case, basically again the child may have vomiting, there may be abdominal distension, tenderness, even a mass sometimes. The child may have gross bleeding, and other radiological signs like pneumatosis intestinalis may be present. In complicated NECs, these things are again more pronounced. The child has full-blown sepsis and may even have perforation of the bowel, which may be seen as a pneumoperitoneum on X-ray. So NEC can present like this. So these are few clinical images in which we can see this is a child whose abdomen is definitely distended, and we can observe the redness in the abdomen, even extending onto the labia, and these are also swollen a bit. So we can see that this is a child who has a red, tender, fulminant abdomen. This is the second child. The picture is a bit cut, but you can again notice that there is again redness around the umbilicus, and we have already put a drain so that this abdomen can be decompressed a bit, and the same inflammatory fluid and the contents have gone through the inguinal hernia, which is a communication of the patent procession vaginalis into the right hemiscrotum, and caused a huge distension of the scrotum also. These are the X-rays which probably will be discussed by Dr. Manisha. So basically NEC is a disease in which the surgeon has to be conservative and the neonatologist or the pediatrician has to be very aggressive. So the idea is to aggressively resuscitate the child, and for the surgeon it is to remove as less as bowel as possible during the surgery, because if you restrict too much bowel, the patient may end with short bowel syndrome. So these are example. This is a very limited involvement of the gut. There was just a single perforation in the terminal ileum which was easily closed, and you can see this is a much more diffuse involvement, which we have patchy necrosis all over the bowel. Now these cases become difficult to manage. So in most of the cases, obvious necrosis is resected but the suspicious areas are put back in the abdomen, drains are inserted, and probably a second look can be given so as to preserve as much as bowel as possible in these cases. Now again you can see in this case there is a NEC, there is a huge perforation. See the amount of gas in the abdomen, and once we open it, this is all covered with feces, and this is a huge perforation there in the ileum. Now interception, as we again I told you, it's a very specific age group, usually 6 months to 2 years of age, in which the child is usually well preserved, and the presentation is with a severe pain, so much severe pain that the child basically lifts his legs on the abdomen, and he has this episode for a couple of minutes, then he becomes normal, he is normal, playful, and again this episode occurs, and this keeps out happening till the child becomes listless, and he may have features of obstruction. So the classical triad that we see is pain, vomiting, and red color and jelly stools, which is because of congestion of the bowel. So this is an important condition in which peritonitis has to be looked for and ruled out, because the treatment of interception is usually reduction, which can be easily done by radiologist under fluoroscopic or ultrasound guidance. The only absolute contraindication to not doing a reduction of this interception in the radiology suite is presence of peritonitis. So if the peritonitis is present, there is an absolute indication to immediately explore the patient, not giving the option of reduction of the bowel in the under fluoroscopic or ultrasound guidance. So this is an image in which we can see this is the colon and this is the ileum, and the ileum is intercepting, that is telescoping into the bowel. It usually has, sometimes it has a lead point. Lead point is the area of which intercepts from where the interception starts. So it is basically at the apex of the interception. It can be a polyp, it can be Meckel's, it can be anything, like it can be a lymphoma, a tumor, a hematoma. So these can act as lead points, and if we dealing with interception, we have to also remove these lead points. Now this is example of ileocolic interception. The ileum intercepted into the ileum and then intercepted into the colon, and even after reduction we can see this bowel is ischemic, so it has to be resected. Strangulated inguinal hernia. Inguinal hernia is a very common disease in children. Roughly 2 to 3% of kids may have inguinal hernia, and of which roughly 10% can strangulate in the first year of life. So you can see that it's a very common finding that we see, in which there is strangulation in the inguinal hernia, and again because of strangulation this bowel may get necrosed and the child may present with peritonitis. Malrotation. Now this is the embryology. If we just revise it, we know that as the gut grows, it goes out of the abdominal cavity, and once it returns back at around 9 weeks of gestation, there is a 270 degrees turn, so that the colon is in front of the SMA and the duodenum, third part of the duodenum, is behind the SMA. So that is a routine embryogenesis and the bowel rotation that takes place during the development of the fetus. So what this normal rotation does is, it has a very broad attachment of the mesentery right from the duodenal ligament of Treves, that is which has a very wide junction from the duodenojejunum junction to the ileocecal junction. So this is a wide attachment of the mesentery which doesn't allow the bowel to derotate or to basically twist. But if the malrotation is present, then you can notice that there is a very less gap, and this bowel, because of this narrow pedicle, can easily rotate and cause volvulus. And once volvulus happens, there is venous congestion, and ultimately there is ischemia and gangrene of the bowel. So we can see a picture like this shows that there is a volvulus, and however the bowel is normal, so we can easily derotate the bowel and do the necessary procedure. Latch procedure is the name of the procedure that is routinely performed. But we are sometimes dealt with this scenario in which nearly whole of the bowel is necrosed, and in these cases there is little bit that we can do for the child. Meconium peritonitis is a type of peritonitis which, although there is a term peritonitis, but what happens is that antenatally only there is perforation in the bowel and the meconium has gone into the peritoneum and caused reaction. Now these children do not have signs of peritonitis at birth. Basically they are present with abdominal distension and obstruction, and this meconium peritonitis is seen as a calcified meconium in the abdomen. So very classical finding in these cases is abdominal distension at birth. As soon as the child is born, we can notice abdominal distension. which makes us suspect meconium peritonitis, which can again be managed surgically if the child has associated obstruction. This is a picture of a huge choledochal cyst. This is the gallbladder, and we can notice there is a perforation in the choledochal cyst, which has been managed by laparotomy. Now these are the very rare cases like Hirschsprung disease. We can notice there is a bowel functional obstruction in the bowel because of lack of ganglion cells. So peristalsis does not happen here, and the proximal area is massively dilated. You can notice here also there is a transition zone, and this is the massively dilated proximal segment. Now because of stasis in this segment, there is bacterial overgrowth which causes enterocolitis. Now with this enterocolitis, this bowel can easily perforate and cause peritonitis. So these were the various causes and common causes in children, and how they are likely to cause perforation and peritonitis in children, how to diagnose them. The radiology will be discussed by Dr. Manisha. Thank you.
मास्क खोल के बोल सकते
हाँ बोल सकते हैं। मैं भूल गया था उसलिए ब्रेसलेस हो जाता है मतलब 40 मिनट।
So I'll be talking about the imaging in acute peritonitis and peritoneal collections abscesses. So imaging is not a pillar for diagnosis. Like diagnosis is most often clear on clinical basis, but still imaging is necessary for the detection of location of the source of infection and the extent of the disease, and whether they are drainable percutaneously or anything can be done percutaneously or you need to open, and how severe it is. So we'll have this whole lot of imaging modalities starting from plain radiographs. Plain radiographs is most often the first imaging modality in cases of especially perforation peritonitis, right? Because it has got a very good sensitivity for detection of free air. Now this is a radiograph where we can see these are the domes of diaphragm, this grey line, and this is the outline of the lever. As you can see, it's the left lobe of lever and the right lobe of lever. So between this dome of diaphragm and the lever, we can see these are the free air where it should not be. So this is a very sensitive modality to detect any free intraperitoneal air. Now which radiograph is best for detection of free air? So we have all these options, either supine radiograph of the abdomen or erect radiograph of the abdomen, erect chest radiograph, or left lateral decubitus of the abdomen. So amongst them, the erect chest radiograph is considered the best because it can detect as little as 1 ml of free air within the peritoneal cavity. We have to, so what are the sensitivity of different imaging modalities? The imaging studies depend on the volume of free air, how much is there, and time interval before the imaging. So when the perforation happened and how early are you acquiring the images. What is the type of imaging modality and how well it is carried out. So if it's a properly done radiograph, when the patient has been made to sit straight, then for 10 minutes at least, then you are able to see as little as 1 ml of intraperitoneal air. So this table shows the average sensitivities of different imaging modalities. Of course, we know that CT is better sensitive than chest radiograph, but of course it incurs significant radiation dose. So erect chest radiograph is considered very good in detection of pneumoperitoneum. What are the signs of pneumoperitoneum free air? So this is an image of a necrotizing enterocolitis. You have already heard about NEC by Dr. Vishesh. Now here we can see this area of lucent, it looks like string of pearls within the wall of the bowel. This kind of air which is trapped within the lumen, within the wall of the bowel, that is considered diagnostic of necrotizing enterocolitis. Now free air in a supine radiograph detection, if it's not a large volume, it may be difficult, but a decubitus X-ray, if we take a decubitus X-ray, then we can see that this is between the liver. This is taken when the left side is down and the right side is up, and here we can see that against the liver surface, this is the free air which is seen as a lucent structure. So what are the signs of supine radiograph? Because most often what you will get in an acute peritonitis patient is supine radiograph, not an erect chest radiograph or erect abdomen radiograph. So in this situation, there are some radiographic signs which are described, like this is called right upper quadrant gas. So see, this is the location of the liver. There should not have been any bowel loop which will be overlapping that of the liver. So if we see this right upper quadrant gas, that is considered significant for pneumoperitoneum. Then what we see is Wriggler sign. Wriggler sign is this is called a Wriggler sign when we can see that both walls of a bowel loop is visible. Normally what we see is that one wall, inside wall of the bowel loop is visible. The outside wall is not well marginated here, as we see. But here what we see, it is lined by air on both the sides. That makes both the walls of the both outlines, inner and outer outlines of the bowel wall visible. So this is abnormal and this is normal. This is called Wriggler sign or double wall sign. Here again we can see, so this is the bowel wall where we can see this is the outer line, this is the inner line of the bowel wall. So this is abnormal, and see, this is normal where this outer wall is merging with the adjacent soft tissues. This is normal. So this is a very important imaging finding. Then falciform ligament, which lies like here, if there is significant pneumoperitoneum, that is outlined by air on both the sides and it will be visible, which it is normally not. Subhepatic gas bubble is one, again this is another sign which is seen in subhepatic gas bubble. This is the falciform ligament sign, which is outlined by air on both the sides. This is the crescent shape falciform ligament. And this is a massive pneumoperitoneum. Here we can see this is what is called a football sign. So these are the abdominal organs, all the viscera, they are centered at the mid part of it, and at the periphery what we see is a gross pneumoperitoneum, and we can also see pneumomediastinum. The air is also going into the mediastinum as well. Contrast studies are usually most often for the site of perforation, they used to be done. Now they are not that commonly done. Once you have documented that there is peritonitis and you see that there is free air on a radiograph, it is enough reason to take it as perforation peritonitis and proceed according to the clinical situation. So contrast studies without CT is very rarely done these days, and if required, usually we do with CT oral contrast. Ultrasound is usually used as a screening tool in the casualty to detect pneumoperitoneum as well as to detect free fluid in the abdomen, which is more important. Now in association with that, we can also have a look at the solid organs like liver, GB and also appendix as well, and in the pelvic organs. But we will also have to keep in mind that ultrasound is a very subjective imaging modality. It depends on the person who is performing it. And so what are the imaging findings you see in a case of perforation peritonitis? Usually you get to see fluid, but this fluid will not be completely black anechoic like normal urine or bile in gallbladder. They will be filled with multiple echoes, as we see in this image. There are multiple small thin echogenic mesh like appearances, and there will be debris also because the fecal content is lying within the peritoneal cavity. So they will be really dirty looking. And there will be these septations. Here we can see these are the septations which are lying within the peritoneal cavity. Now this is not normal. This appearance is normal and this appearance is abnormal. This again within the bowel loop we can see this echogenic thickened mesentery. This is again abnormal. They are all suggestive of peritonitis. Now on CT, if we give oral contrast, they help to identify the location of leak. Here we can see this is the location of leak, and the contrast is leaking inside the peritoneal cavity. So we can see this is the liver, and outside the liver this is the oral contrast which is leaked within the peritoneal cavity in a case of perforated duodenal ulcer. Now again, sometimes in peritonitis, if the patient is in a really bad condition, you may not be able to give oral contrast in all of them, but demonstration of free air within the within the peritoneal cavity on a CT is good enough, and many times you may be able to show the rent in the bowel on the CT itself. So even if they are like this small, you will be able to show the air within the peritoneal cavity. And sometimes in the CT you can see the cause of the leak, like here we can see these are the diverticuli. Now there is a diverticular perforation which has led to this pneumoperitoneum and peritoneal abscesses here. This is another case of perforated appendix. We can see this inflamed appendix which is enlarged and thickened with enhancing walls, and this is the collection in the periappendiceal location suggestive of inflammation in periappendiceal perforation. This is a very rare situation of a biliary peritonitis where there is a spontaneous biliary perforation, where we gave contrast through this drain tube and it communicated freely with the CBD. So this was a spontaneous perforation of the gallbladder and CBD. So this was yet one case of biliary peritonitis. Sometimes if you see the discontinuity in the wall of the GB, you may be sure that yes, this is rising from the gallbladder. Now TB peritonitis can present with multiple findings. There will be ascites, peritoneal thickening, omental thickening, and mesenteric inflammation. So this is ascites, these are the septations, this is the omental thickening, and this is the mesenteric thickening in between the bowel loops. This is called sandwich sign, and this is the omental thickening, echogenic omental thickening. On the CT, what we see is a high attenuation ascites. This is the ascites which is a little denser than what normal fluid should be. So this is high density ascites, wall thickening of the mesentery, interbowel loop fluid, this matting or palisading of the bowel loops. They are all findings suggestive of tubercular peritonitis. Sometimes they may be associated with necrotic lymph nodes in peritonitis. Like this is yet another imaging finding of tubercular peritonitis, where we can see this is almost cocoon formation has occurred. So this is a smooth thickening of the entire peritoneum which has encased the bowel loops within. This is a smooth enhancing peritoneal thickening with fluid entrapped inside. This is in a neonate where we can see meconium peritonitis. This is very unique to the neonates. Here we can see a neonate who is having a calcification within the abdominal radiograph on the right side, and if we do ultrasound, there are calcification within the peritoneum. So they are not within any solid organs, they are within the peritoneum, and this is a thick debris filled fluid within the abdomen. So these are suggestive of meconium peritonitis. Now what are the intra-abdominal abscess? So once there is acute peritonitis, they may be localized to some places where they localize like abscesses. So they can be seen as a small gas bubbles or fixed air fluid levels. Like this is an appendiceal abscess where you can see air fluid level in the right lower quadrant. So see, what are the CT findings? Again, CT findings will be same, but here the fluid will be localized to one part preferentially rather than diffusely uniformly expanding over the abdomen. There, like here, it is located in the left lower abdomen. So this is the right subphrenic abscess where ultrasound has been done, and this is a pleural effusion. This is the diaphragm, this is the liver, and we can see the fluid abscess is localized in the subdiaphragmatic location. So what are the causes of right subdiaphragmatic abscess? This is one of the commonest site where we get abscesses, ruptured liver abscess, and this is one common complication of this. So how does it look like? It again looks like a lentiform collection between the diaphragm as well as the liver, and again the characteristics will be the same. There will be fluid collection, air collection may be there, and the walls will enhance. Subphrenic abscess, again this is another subphrenic abscess which followed by grade 4 injury, the hepatic dome. This is a gallbladder perforation which led to some hepatic collection. You can see this is the rent in the gallbladder, and then there is a collection in the subhepatic location. Then this is amoebic liver abscess which has ruptured, and there is a collection over here, but it has shown transdiaphragmatic migration, and now it is in the pleural cavity. So it may be mistaken only in a chest radiograph as a hydropneumothorax per se, but the source lies under the diaphragm. Then right subhepatic abscess, because of post liver transplantation there was multiple abscesses. There are paracolic abscesses which can form in the right paracolic gutter or in the left paracolic gutter. Left subdiaphragmatic abscesses are less common than right subdiaphragmatic abscesses because there is limited access because of phrenicocholic and falciform ligaments. Typically, if they occur from the stomach or the colon. So there can be perforated gastric ulcer or after splenectomy. Now, what is the second role of radiology in cases of acute peritonitis and peritoneal abscesses? Percutaneous drainage. Percutaneous drainage may often be the first line treatment. Many times the patient may be too sick to undergo any open surgery, laparotomy or laparoscopy. In that cases, the patient to control the sepsis, we may straight away go percutaneous drainage, and that may suffice. Like here we can see this is the abscess in the right paracolic location, and then it has been drained by a pigtail catheter in position. This drainage can be done under ultrasound guidance. Here this is an ultrasound picture of an abscess in which this echogenic needle has been put inside to drain the pus. Now, before I close, there are some contraindications where you should not contain for percutaneous treatment. One, if there is significant coagulopathy uncorrectable, and there is no percutaneous access which is safe. By safe we means we should not traverse the colon, we should not traverse the blood vessels and very vascular organs like spleen or pancreas, because in pancreas there may be ductal injury and pancreatitis. So you will have to have a clear path through which you can put your needle, or there should be no coagulopathy, and the patient can be properly sedated, so there is no breath-hold issues and there is no movement problems related to the movements. So with this I will end this radiological perspective.
कहाँ क्या करना है इसमें?
नहीं,
ये लगाना है? आया कहाँ? कहाँ आया? कहाँ आया? ये आया, इसमें देखिए।
हाँ, थैंक यू।
यार ऑफ कर दें। So today I will be discussing spontaneous bacterial peritonitis. So what is this spontaneous bacterial peritonitis? It's an important complication of ascites. So SBP will develop in those patients, those who are having ascites, and it is infection of fluid which is present in the abdomen in absence of any intra-abdominal surgically treatable source of infection. So if anybody has any intra-abdominal surgically treatable source, then we will not brand it as spontaneous bacterial peritonitis. And this is one of the most common cause of morbidity and mortality in patients with cirrhosis with ascites. Means all those patients of cirrhosis which have decompensated with ascites, they are more prone to develop spontaneous bacterial peritonitis, and prevalence is 8 to 27%. So there are certain terms which you should know. One is when there is spontaneous infection, it may be spontaneous bacterial peritonitis or monomicrobial non-neutrocytic bacteriacitis. Third is culture negative neutrocytic ascites. Then there may be secondary bacterial peritonitis, that is intra-abdominal surgically treatable source of infection, and polymicrobial bacteriacitis, but I'll come to that. When polymorphonuclear count is less than 250 per cubic millimeter, and this is essentially diagnostic of gut perforation by needle. So in SBP we have a positive ascitic fluid culture, while in culture negative neutrocytic ascites, as the name indicates, they have a negative ascitic fluid culture. And the third one is when ascitic fluid culture is positive but polymorphonuclear count is less than 250, right? So what are the risk factors? Those who have significant or severe liver disease, means child B or C cirrhosis, their bilirubin is high, more than 3.2 to 4 milligram per deciliter, and prolonged prothrombin time. And the second important factor is low ascitic fluid albumin concentration. When the albumin concentration is low, protein concentration is low, that means opsonic index is low, so they are more prone to develop spontaneous bacterial peritonitis. Patients after GI bleed, means after variceal bleed, they are also more prone to develop spontaneous bacterial peritonitis, and patients having urinary tract infection or other infection, they can also develop SBP. So the present concept as far as pathogenesis goes is translocation of bacteria from lumen of gut to mesenteric lymph node, and these are one of the first step in the pathogenesis of spontaneous bacterial peritonitis. The normal gut mucosal function, that the mucosa acts as a selective filter, and gram-negative aerobic bacteria, they translocate more easily as compared to gram-positive and anaerobes. So gut mucosa in setting of cirrhosis is more leaky, and there is alteration in permeability also. So predisposing factor for translocation are decreased local defenses, ischemia, reperfusion injury, maybe after post GI bleed, endotoxemia, and bacterial overgrowth. As I have said, that bacterial overgrowth, that is also an important predictor, and it's defined as more than 10 raised to the power 5 colony forming unit per ml of jejunal fluid, and or more than 3 for colonic flora per ml of fluid. And the predisposing factors are intestinal dysmotility, decreased intranumeral defenses, acid suppression therapy, and hypochlorhydria. Then cirrhosis with ascites, they have low serum complement level, neutrophil and reticuloendothelial system dysfunction is common, and portal hypertension decrease bacterial clearance by hepatic reticuloendothelial system by forming portosystemic channels. So 50% of patients with SBP, they have bacteremia at the time of diagnosis of peritoneal infection. Ascitic fluid is a fertile soil for infections, and they also have low protein in cirrhotics. They are particularly more prone to develop spontaneous bacterial peritonitis. They have poor opsonic activity. So what are the clinical features? As far as signs and symptoms are concerned, patients may be asymptomatic, they may have fever, abdominal pain, tenderness, rebound tenderness, or change in level of consciousness. So one should have a high suspicion index if you want to make a diagnosis of SBP, and a low threshold for performing paracentesis. That is also very important. So the moment a patient with cirrhosis or with ascites comes to you with fever or say altered sensorium, we should go for paracentesis, and many, means 1/3 of these cases may be totally asymptomatic. paracentesis, I will again emphasize, it's a very safe procedure, and even in the presence of thrombocytopenia or coagulopathy, this can be performed safely. So what are the indications for diagnostic paracentesis? If there is local signs of peritonitis, systemic sign of infection, worsening azotemia, hepatic encephalopathy, following GI bleed, or deteriorating liver markers or laboratory tests. So for diagnosis, ascitic fluid polymorphonuclear count of more than 250 is diagnostic of ascitic fluid infection until proven otherwise, and sensitivity and specificity is more than 95%. In patients with bloody ascites, we try to subtract one polymorphonuclear cell for every 250 RBCs, and ascitic fluid culture taken in blood culture bottle at bedside have a higher yield, and the minimum amount of ascitic fluid to be inoculated is around 10 ml. So just remember these 3 points. These are important points, that we try to collect blood culture ascitic fluid in a blood culture bottle at bedside, and we put at least 10 ml of ascitic fluid in that bottle. These are the bacteria. Most commonly we see E. coli and Klebsiella. So other relevant investigations are complete hemogram including ESR, coagulation profile, electrolyte, LFT, KFT, blood culture, urine culture, X-ray chest, and we try to rule out secondary peritonitis by doing an abdominal X-ray or ultrasound and anaerobic cultures. So polymicrobial bacteriocystis that contain multiple organisms, but counts are less than 250 per cubic millimeter, and essentially this is diagnostic of gut perforation by paracentesis needle. Secondary peritonitis, I think that will be covered. So as far as management of SBP is concerned, what is the rationale of treating this? The aim should be to eliminate infecting organisms, expansion of intravascular volume to counter renal impairment, and changing the microbial flora of the gut. So goals of management, as far as goals are concerned, we try to treat acute episode, we try to prevent recurrences, and give primary prophylaxis in high risk group. As far as treatment of acute episode is concerned, early treatment is important for better outcome. We should not delay it. It should be started at the earliest on the mere suspicion. And diagnosis can be made in a very short time by ascitic fluid cell count. And we start antibiotic if polymorphonuclear count is more than 250. Culture usually takes 24 to 48 hours, so we don't wait for culture report. The moment you see polymorphonuclear count of more than 250, you start with the antibiotic at the earliest. So what is the best antibiotic therapy, and what is the strength of evidence supporting antibiotic therapy in SBP, and what should be the ideal duration? So available antibiotics are cephalosporins, third generation cephalosporin, especially cefotaxime or ceftaxone, amoxiclav combination, ofloxacin, norfloxacin or ciprofloxacin, and aminoglycosides or aztreonam. These are the antibiotics which are available. So generally we start with 2 gram IV 8 hourly cefotaxime for 5 days, and if serum creatinine is more than 3 milligram per deciliter, we can increase the dose interval, so 12 hours. No loading dose is required, and 5-day therapy is as effective as 10-day therapy. So we generally advise antibiotic for 5 days to 7 days. And ascitic fluid culture becomes sterile after 1 dose of cefotaxime in almost 85 to 86%, 80 or 90% of patients. And if it is not responding, we repeat ascitic fluid count after 48 hours. So if there is no response, then the cause of that inappropriate or low response is inappropriate antibiotic or dose. There may be resistant organism or polymicrobial infection or secondary peritonitis. So the moment you see that there is no response, you look for the causes of secondary peritonitis. And as I have said, that empirical antibiotic can be started immediately. As I have already told you, that as far as assessment of response is concerned, we repeat paracentesis after 48 hours. So treatment failure, we label this as treatment failure if there is clinical deterioration on therapy, or less than 25% decrease in polymorphonuclear count in paracentesis or in the ascitic fluid compared to pre-treatment value. And if there is treatment failure, then we can modify antibiotic therapy according to susceptibility or empirically and consider the possibility of secondary peritonitis. So what are the adjunct to antibiotic therapy? We can use prokinetics that can shorten intestinal transit and decrease bacterial overgrowth and translocation. We can also use probiotic to restore the mucosal barrier function and decrease translocation. We can give bile acids and albumin infusion to prevent renal complication. As far as prevention of recurrence is concerned, then recurrence is a rule. In fact, once patient develop SBP, the 70% chances that within a year he may have another episode of SBP. So, who are at risk? Patients after GI bleed with ascitic fluid albumin of less than 1 gram per liter, those who survived a prior SBP episode, and hospitalized cirrhotics with ascites. So for prevention of recurrence, if there is a probability of first episode of SBP after 1 year, more than 50% in patient with low ascitic fluid protein and increased bilirubin, they have high probability, and 40% SBP during hospitalization and 60% is community acquired. Then for that, for prevention of recurrence, we can give oral Norflox 400 milligram per day, and then we can use other antibiotics as well, depending on the cost in various situations. As far as prophylactic measures are concerned, we advise patient not to take alcohol, because you know alcohol can also lead to leaky gut and increased permeability. We should try to shorten the stay of a cirrhotic in the hospital, improve nutritional support, diuretic therapy, because you see diuretic will mobilize ascites, and so protein concentration may go up and opsonic index may improve. Then treatment of asymptomatic bacteriuria, systemic antibiotics, and we avoid instrumentation unnecessarily. All patients who survive episode of SBP be evaluated for liver transplant. As far as secondary prophylaxis is concerned, again we give these antibiotics. These are the various reports, we can skip. For primary prophylaxis, especially in cirrhosis with GI bleed, that there is increased risk of developing SBP within a day. So 20% will already have infection at the time of admission, and 50% will develop infection after hospitalization. So we go for selective intestinal decontamination with oral norfloxacin, which is effective in preventing infection. And the incidence of SBP is around 3% in treated group versus 17% in control, and no difference whether we give oral antibiotic through oral route or intravenous route. So as far as primary prophylaxis of SBP concerned, those who have no GI bleed, we can give long-term prophylaxis with ciprofloxacin or norfloxacin, and in them there is pretty high incidence of emergence of a resistant organism in the ascitic fluid. As far as role of albumin in SBP is concerned, the renal impairment can be prevented by intravenous albumin, and a randomized trial has clearly shown that those patients who received albumin in the dose of 1.5 gram per kg within 6 hours of detecting infection, followed by a second repeat dose of 1 gram per kg on day 3, then the renal impairment and hospital mortality and survival, 3-month survival, all have shown improvement. As far as prognosis is concerned, long-term prognosis is extremely poor, and in-hospital mortality is around 50% in the past, but with newer studies and with better management of these patients with albumin and antibiotic, that has gone down to some extent. So in conclusion, we can say that SBP is an important complication of cirrhosis with ascites. It is present in 10 to 30% of patients. Gram-negative bacilli, especially E. coli and Klebsiella, are the commonest organism. Diagnosis can be made on ascitic fluid examination if polymorphonuclear count is more than 250 per cubic millimeter. Culture yield can be increased by inoculation in blood culture bottle. Cefotaxime is the preferred drug for empirical therapy. and selective intestinal decontamination with quinolones are recommended for primary and secondary prophylaxis. Patient with GI bleed should be given antibiotics for 7 days during hospitalization, and primary prophylaxis has shown survival benefit in patients with poor liver function. As long-term prognosis is poor, other options like liver transplant should be explored. Thank you. क्यों भाई टाइम है ना तुम्हारे पास?
हाँ मैं फटाफट कर कुछ ज़्यादा नहीं बचा थोड़ा थैंक यू सो मच yeah I know thank you Dr. Saraya. I hope my presentation is still there. Yeah, so till now we have talked about we covered primary peritonitis by Dr. Saraya. I have already talked about secondary peritonitis. Then Dr. Vishesh Jain has talked about the pediatric causes and management of peritonitis. Dr. Manisha has talked about the radiological part, and what is left is a bit about the tertiary peritonitis, as I said in the classification earlier. So I'll just, because time is short now, I'll just quickly cover it. So what happens is I'll start from the post-operative care again and then go on to the tertiary peritonitis. In the post-operative period, we have to look at the vitals of the patient once after we have operated, monitor them very closely for a progressive improvement, and which is expected over the next 2 to 3 days. Patient improves significantly and starts accepting orally. So once that happens, it looks like patient discharge within 5 to 10 days, depending on the condition of the abdomen. Sometimes if the patient has an open abdomen, they may require a prolonged hospital stay. Now, sometimes there can be a failure of improvement. That can be a persistent or recurrent infections. That means you may not have drained one pocket of pus, or there may be a re-leak or a re-perforation somewhere. Patient may have ventilator-associated pneumonias or ARDS because of severe sepsis, resistance to antibiotics, central line infections, UTI to opportunistic infections. So all these things can lead to a persistent or recurrent infection. And this is not uncommon actually. If you see, about 15 to 20% of cases will have some sort of a condition like this. And the workup involves cultures, radiology and a CT abdomen, because in an operated patient, it's very difficult to clinically know what's happening inside the abdomen. Because sometimes a small abscess will not produce any signs, and a CT of the abdomen in this setting is very, very useful. And Dr. Manisha has already talked about it, I think. So when we have a patient who is otherwise improving, starts throwing high-grade fever, let's say on 4th day or 5th day, we should change their antibiotics without waiting for culture report, because they can get sick very fast. Now their microorganisms are hospital required. They have already been operated. There have been various catheters being put. So they require a higher grade antibiotic like piperacillin tazobactam combination or a magnemycin, along with a broad spectrum cover. So we send the things to culture, but we don't wait for the report, because by the time the report comes, the patient may become very sick, and hence we need to, that's one point you must remember, is change antibiotics without waiting for culture if the patient throws signs of sepsis again. Then obviously depending on the CT findings, we need to do an image guided drainage of collections, or in case of multiple collections or where the collections are not amenable to image guided drainage, we need a surgical exploration and drainage. And then obviously these patients continue to need intensive care and support. The poor outcomes are due to persistent infection, or if there are enterococci in the culture, or multi-drug resistance, or patients are immunocompressed, or there are associated fungal infection. They can lead to poor outcomes. And poor outcomes in terms of high mortality can occur in this subset of patients who are elderly, who are malnourished, who have malignancy as an underlying cause, high scores. I have not touched the scores because I thought it is beyond your scope of your at the UG level. Preoperative organ dysfunction, if you have renal failure or ARDS already there at the time of presentation. Presence of complex abscesses. Okay, so all these factors predict a poor outcome. A mortality in uncomplicated peritonitis is less than 5%. Obviously, it depends also on the cause. Severe peritonitis has a high mortality, and a multi-organ failure, that means renal failure or patient requiring anatropes along with renal failure or ARDS, have a high mortality. So it's a very, very serious condition. A brief word about tertiary peritonitis is when we have inadequate source control. Supposing you have closed the perforation but it's not been closed properly, or there is another fresh entry perforation, and there are other factors which I just discussed: resistant organisms, enterococci, organ system failure. All these can lead to what is known as a persistence of infection, and these are the incidents of post-operative abscesses after, related to the cause. So what do we do? Okay, so we do a percutaneous drainage, do a CT scan, we change their antibiotics, we do a percutaneous drainage, which is preferred over surgical drainage, and based on that we manage the patient. If the surgical drainage fails, then we do resort to surgery. Okay, so surgical drainage will be a failure of percutaneous drainage when there are multiple collections which cannot be drained image guided. There are collections with a significant solid component which requires debridement, especially in pancreatitis. Simultaneous management of source of ongoing contact. Suppose there is a leak also, so you need to, obviously with percutaneous management you cannot block the leak, you have to suture it. So then you have to do a surgical drainage, or there is generalized peritonitis and patient is unstable, we need a surgical drainage. That means a re-laparotomy and treatment. Since the appendicular abscess, I'll discuss briefly now the appendicular abscess, subphrenic abscess. These are the areas where pus spreads, okay, through the suprahepatic space, to the subhepatic space, to the paracolic gutter, to the pelvic abscess on the right side. On the left side, perisplenic abscess or a subphrenic. So both sides you can have subphrenic abscesses. Subphrenic means below the diaphragm but above the viscera. And these are common after peritonitis because these are the areas where, these are the areas which sometimes remain undrained. And they can also be due to leaks, ongoing leaks. You have anastomosis bowel but it continues to leak, any bile leak. So these are commoner sort of a residual infection, and they come under the category of tertiary peritonitis. The first symptom is high-grade swinging fever with chills and rigors, tachycardia. Because of the subphrenic location, they can have shoulder pain and hiccups. There can be deterioration in the general status, tachypnea, hypotension, decrease in urine. All these are signs of sepsis. So basically, this is a resurgence of signs of sepsis along with shoulder pain, which gives an indication that it could be a subphrenic abscess. And obviously, the counts are raised, the CRP is raised. The investigations may be have been discussed with Dr. Manisha. Chest X-ray may show a raised diaphragm. Because of the collection, it may show a raised diaphragm. Ultrasound can be done, but the CT of the abdomen is the investigation of choice in any case of a tertiary peritonitis or a residual infection. And depending on that, the CT findings, which I already discussed, antibiotics, image guided drainage and surgical drainage may be required. So just to conclude this seminar, peritonitis is a serious condition with high morbidity and mortality. Diagnosis is mainly clinical in the present era as well, where a detailed history and a clinical examination and a repeat clinical examination if equivocal will give you the diagnosis in most of the cases. Early diagnosis and prompt management is absolutely important. The surgery has to be done within few hours, not the next day. And whatever be the time, whatever be the day, it be a holiday, you have to treat them within few hours. Aggressive fluid resuscitation is a mainstay of resuscitation. Fluids have to be given very liberally. Broad spectrum antibiotics, and of course the surgery is the definitive treatment. A prompt laparotomy, source control, lavage and drainage remain the mainstay of therapy. Thank you so much for your kind attention. Thank you. Thanks. I know this YouTube you can't interact, so any questions you can send me at my email sandeep_aims@yahoo.co.in. Okay, so you can just send me I can just write it down here. So my email is sandeep_aims@yahoo.co.in. So please send in your questions at this email and I'll be happy to answer them. Okay, thank you so much for your attention. I think tomorrow we have a class on renal transplantation. I'll be again be the moderator for that, or maybe one of the speakers. So see you tomorrow. Have a nice day. Bye. Thanks.